Muy buenas noches, señoras y señores miembros de la Academia Argentina de Cirugía y miembros de la comunidad quirúrgica interesados en la marcha de esta academia. Esta es la sesión online del 29 de septiembre de 2021, donde contaremos con un invitado especial. Antes de que eso, habiéndose ya discutido y aprobado online la sesión el acta de la sesión anterior, le pido al señor secretario general, doctor Manuel Montesinos, que por favor nos presente los asuntos centrados. Doctor Montesinos.
Muchas gracias, doctor Figari. Buenas tardes a todos. Se recuerda a los asistentes de estas sesiones que pueden registrar su asistencia en el formulario del link que se copia en el chat en vivo, ya sea en las categorías de miembros de la academia o como no miembros. La asistencia al 50% de las sesiones del año anterior es uno de los requisitos para ingresar como miembro asociado o como para pasar de miembro asociado a miembro académico. Aquellos miembros de la academia que estén interesados en hacer algún aporte o comentario oral sobre los trabajos leídos en las sesiones deben hacerlo saber con anticipación a la Secretaría a fin de ser incluidos en el estrado del Zoom. La participación estará limitada a un máximo de 5 minutos. Existe interés en que los trabajos leídos en esta academia sean enviados para su publicación a la Revista Argentina de Cirugía. Los manuscritos deberán ser enviados por los autores a la Secretaría de la revista, la presentación deberá adecuarse al reglamento y todos los trabajos serán enviados para revisión por pares de acuerdo con las políticas de calidad editorial. La presentación de casos clínicos y de videos científicos es una de las modalidades que la comisión directiva considera incluir en las próximas sesiones. Para tal fin, esta comisión directiva enfatiza en la necesidad de que los miembros de la academia envíen casos interactivos y o videos científicos para integrar la sábana de futuras sesiones. Concurso a nuevos miembros. En este reciente llamado se han inscrito los doctores Federico Brahim como para miembro correspondiente nacional y las doctoras Rosa Angelina Pache, Victoria Ardiles, Margarita Mercedes Ortiz y el doctor Jorge Omar Monestés para miembros asociados. La próxima sesión, miércoles 29 de septiembre, escucharemos la comunicación Impacto de la pandemia por COVID-19 en la formación de alumnos de la carrera de posgrado de cirugía general en un hospital COVID-19. De los autores Gambialtes, Pomillo, Ronzano y Gabosto. El redactor será el doctor Luis Saroto. Nada más.
Muchas gracias, doctor Montesinos. Como anuncié previamente, hoy tenemos un invitado muy especial, el doctor Corrado Marini, que será presentado por un miembro de la comisión directiva de la academia, el doctor Gustavo Tismineski, a quien le pido que en este momento se conecte a ese efecto. Doctor Tismineski.
Muchas gracias, señor presidente, por el honor de presentar a un referente internacional en la cirugía del trauma. Dr. Marini, first of all, I want to thank, on behalf of the Academy, for joining us in this session. I apologize for introducing to you with our audience in Spanish. Muchas gracias también a nuestro amigo Patricio Petrone por su desinteresada colaboración para contactar al Dr. Marini. El Dr. Marini es Fellow del American College of Surgeons, profesor de cirugía en New York Medical College, recibió su título de médico en la Universidad de Nápoles, completó su formación quirúrgica en Maimonides Medical Center en Brooklyn y realizó un fellowship en cirugía vascular en Long Island US Medical Center en New Hyde Park, donde se desempeñó como vicepresidente de educación quirúrgica hasta 2009. Más tarde se desempeñó como jefe de la división cirugía de trauma, cuidados críticos quirúrgicos y cirugía de cuidados agudos del departamento de cirugía del Hospital Universitario Westchester Medical Center. Actualmente se encuentra a cargo de la sección de educación e investigación quirúrgica del departamento de cirugía del Jacobi Medical Center en el Bronx. Thank you, Dr. Marini.
Muchas gracias, doctor Tismineski. Bueno, habiendo presentado el doctor Tismineski al doctor Marino, el doctor Corrado Marini va a hablarnos en este momento sobre su experiencia en el manejo del trauma de las venas hepáticas. El doctor Marini va a hacer la presentación en inglés. A posteriori le vamos a pedir al doctor Patricio Petrone que haga algún comentario respecto a la conferencia del doctor Marini y luego abriremos la discusión en forma habitual. Dr. Marini, it's a pleasure for us to have you as guest in our Surgical Academy, and we are all waiting for your conference. So if you want to share your screen, we will here waiting for your wonderful experience. Okay. No, Harry, it's okay.
So I want to thank the Surgical Academic Society in Argentina, Dr. Figari, and all members, and in particular Patricio, for having coordinated this effort. I'm going to briefly introduce the incidence and the mechanism of injury of liver trauma in the US. Spend a little time.
Dr. Marini,
yes.
You're not sharing the screen.
It's not sharing?
No.
Now it's coming, yes.
Okay.
Yeah.
Yes, perfect. Thank you.
Thank you.
Okay, so I will focus briefly on the incidence of liver trauma in the US, review the anatomy of the liver segments, and in particular the hepatic veins, review the revised AST grading system that we use, and injury patterns classification by CT, how to establish the diagnosis of the injury, and then I will review the role of atriocaval shunts, total vascular exclusion, and veno-veno bypass, including the role of the hemostatic agents, including the role of the aquamantis, and then focus on the non-operative management, including damage control, resuscitation, packing, and angiography. Few words about the role of liver transplantation, the issue concerning what has happened to mortality over the past 3 decades, some new issues concerning unconventional treatment modalities, and finally, I'll share with you my personal experience and the conclusions. These are the data that we have in the US. They show the incidence of liver trauma that has increased from 2.99 per 100,000 people in the US in the early 90s to 13.9 in the last decade. And what you can see basically that an interesting phenomenon has occurred in the US. The percentage of increase in liver trauma is the result mostly of blunt trauma. The number of patients with liver trauma from penetrating injuries have remained stable. It actually, up to last year, has decreased to 16%. Unfortunately, though, in New York, in the last 6 to 8 months, due to the changes related to the pandemic, we have seen a huge increase in liver trauma from penetrating injuries. In fact, liver trauma in our facility has risen by close to 300% from mostly gunshot wounds. To understand the liver trauma, in particular, the issue concerning the approach to the hepatic veins, one must understand the anatomy of the 3 hepatic veins. As you can see in this slide, based on the Q-dose segments, the right hepatic vein basically drains the posterolateral segments 6 and 7, and the medial anterior segments 5 and 8. And it demarcates the division between the 7-6 and 8-5 segments. It has a length of about 12 centimeters. Most of this length is intraparenchymal. The distance between the confluence and the margin of the liver ranges between 1.5 and 2 centimeters. For those who do liver surgery, they know that control of the right hepatic vein is really tricky because there is a membrane at the confluence that must be dealt with. And there is very little room for error here. The left hepatic vein has a length of 8 to 10 centimeters intraparenchymally and has a little shorter course, which is typically about 1 centimeter. The middle hepatic vein has a length of 10 to 12 centimeters long and basically demarcates the lateral and the medial portion of the liver. Here are depicted basically the confluence of the right hepatic and the joints of the middle hepatic vein and left hepatic vein with the cava. This is important information that one must take into consideration when decided how to approach the injury to the just hepatic veins. We will go over the anterior posterior approach to the injury, and we'll discuss the advantage and disadvantage of each approach. But a voice of caution has to be placed by understanding that these are short segments, not easily controllable, even for hepatobiliopancreatic surgeons. The portal vein basically has a different anatomy, demarcates the lobes in a horizontal fashion with the tributaries to each lobe being vertically. It provides about 75% of the blood flow to the liver, and of note, it provides 50% of the oxygenation, while the hepatic artery provides 25% of the flow, the arterial flow, and it provides also 50% of the oxygenation. This information is key to understand that is very important because we can ligate successfully the hepatic artery without suffering any ischemic injury to the liver. This is the revised AST grading of liver trauma, was revised in 2018, and basically grades the liver in grade 1 to 6, and grade 1, 2, and are considered minor injuries. They occur frequently. Of note, one has to realize that grade 1, 2, and 3 constitute more than 80% of the liver injury, and the injuries that we're going to discuss, which is grade 4 and 5, because grade 6, most of these patients are dead, constitutes about 15 to 18%, depending where you are. And in particular, the grade 5 range between 3 and 5%. If you look at the IS score, which is the abbreviated injury score, if you look at this score, if you have just an isolated grade 4, you have an ISS of 16. And if you have a grade 5, you have an ISS of 25, which means really from the standpoint of trauma, you're severely injured. Now, what has been the revision of 2018 has added the vascular injury with active bleeding contained within liver parenchyma for grade 3, vascular injury with active bleeding breaching liver parenchyma into the peritoneum for grade 4, and vascular just hepatic caval injury, vascular, which were already there. So the only two additions to the AST grading by the 2018 revision has been the vascular injury component for grade 4 and grade 3. So what are the most common pattern of just hepatic vein injury that one notice on a CT scan? Well, this pattern that I prefer to use has been popularized by Buckman in 2000. It divides the injury by a type A and type B. A type A injury, this pertains to just hepatic vein injury, it tells you that the injury to the hepatic vein is mostly intraparenchymal. There is a disruption of the liver parenchyma in capsule, and sometimes even the falciform. Most of the suspensory ligaments may be disrupted, and the bleeding occurs through the liver substance without bleeding behind the liver on the side of the liver. The type B injury is an hepatic injury that is mostly extraparenchymal. It's associated rarely with massive disruption of the liver parenchyma, and the disruption of the suspensory ligament occurs not very commonly, and the bleeding occurs around the liver or sometimes in the chest if the injury has been caused by a gunshot wound or a stab wound to the right thoracoabdominal region. Both type A and B type of injury can be caused by blunt or penetrating trauma. Type B injury is more commonly associated with penetrating trauma in the right thoracoabdominal region. The amount of free venous bleeding that occurs with idiopathic venous injury, whether type A or B, depends on the extent of the venous laceration, as well as on the amount of disrupted liver parenchyma. Shown here is a grade type A injury in a patient with massive trauma from an MVC. And this injury is associated with a huge amount of ruptured parenchyma. And the question is, should this injury be approached with an anterior approach or a posterior approach? Since most of the injury is intraparenchymal, we'll discuss the best approach to this injury is through an anterior approach to an hepatotomy. This injury, conversely, is in a 23-year-old who fell from a motorcycle while driving at 60 miles per hour. This injury shows the injury of the left hepatic vein, and we will discuss which is the best approach to this injury, which is associated with minimal blood loss, but still potentially a little injury. So what leads to the avulsion of the hepatic vein from the cava is basically a rotation movement that is typically associated with the loss of suspensory ligaments. And shown here, in fact, is a type B right hepatic vein that is being avulsed from the cava. There is little blood. This is still contained, but this is an injury that can be lethal if managed inappropriately. In fact, shown here is what happens to an injury. And here you see the right hepatic vein completely disrupted. This has been approached to an anterior hepatotomy. So what has happened to hepatic trauma? When I basically trained and I finished my training, all patients with blunt trauma were evaluated. If we could not evaluate them clinically because of unconscious status or alcohol, we did a DPL. We did a DPL, we put 1 liter of saline in the abdomen, we retrieved 250 milliliters, we then basically send the specimen, and if the red blood cell count was greater than 100,000, we operated on them. And we did this during my training, and unfortunately I continued to do it until 1990. And about 80% of the time, once we did the laparotomy, the liver injury was not bleeding, probably did not require surgery, and we were left with the issue, are we going to drain or not drain? The teaching at the time was even moderate liver injury, get a drain, so we put a JP in. So things start changing in 2000 when we start understanding that we were doing in the 90s and early 80s was not the right thing. So there's been an evolution from aggressive surgical approach to non-operative trauma. The retrohepatic vena cava and major hepatic vein injury represent a challenge because of their difficult location and difficulty in controlling the bleeding. This injury occurs 15% of the time. And the question is, can this injury be managed safely without an operation, that means without surgical control or a direct repair? So one of the things that I have experienced during my training is that about 1/3 to 40% of the patients with major complex liver injury involving the hepatic veins of the cava arrived in extremis and required thoracotomy. All the patients that had the resuscitative thoracotomy, in my experience, end up dying because we were not able to save them. And the majority of these patients at post-mortem were found to have basically massive blood loss in the abdomen. So why did my training attendings and why I did not embrace myself early on in my career the non-operative management? One was the belief that was inculcated in me that hepatic hemorrhage cannot stop spontaneously. It needs some fixing. And two, if you didn't drain the bile, the patient would develop biliary fistula, infectious complication, biliary peritonitis. And the third one was, well, you're going to miss additional injuries. All of these reasons led to the people not embracing basically non-operative management. So one of the issues that has occurred with the development of CT scan is, what do you do with a stable patient who has the hemoperitoneum? And does the amount of hemoperitoneum has any predicted value in deciding what to do? That means, should a large amount of hemoperitoneum necessarily transpose in an intervention? So in the US, we have two models that we use to establish the amount of hemperitoneum. One is the 7-compartment model that includes perihepatic and perisplenic space, Morrison pouch, pericolic gutters, floating intestinal loops, and Douglas pouch. And if you have one compartment, the hemoperitoneum is minimal. That means typically corresponds to 200 to 300 milliliters of blood. If you have two compartments, you have moderate hemoperitoneum. That corresponds to 500 or more blood, and large, which correspond to 1 liter or more blood if you have 3 compartments. I favor the Featherly classification. In fact, at Westchester and where I am now, we use the Featherly classification. Basically, you have a perihepatic space, perisplenic space, Morrison pouch, the pericolic gutters, and the pelvis. If you have limited blood around the liver and Morrison pouch, you have a minimal hemoperitoneum. If you have a perihepatic, perisplenic, and Morrison, and the 2 gutters, you have moderate. And if the blood is going in the pelvis, you have a large hemoperitoneum. Thus, the amount of hemoperitoneum leads one to decide about the treatment modality with respect to non-operative management. That means, are you going to engage on interventions such as angiography and therapeutic angioembolization based on the presence of a large hemoperitoneum? My personal feeling is that patients with a large hemoperitoneum have a higher failure rate, and therefore we routinely do diagnostic angiography in these patients. However, this is not based on evidence, it's based on my personal experience. So my approach and the institutional approach that I fostered when I was at Westchester was we divide basically the CT classification of liver injury based on the amount of extravasation, the location of the extravasation. If we have blood that extravasated into peritoneal cavity and the CT scan had been done in a stable patient and the patient remains stable, that patient goes to the angio suite to have an angiogram and basically a therapeutic angioembolization. If the patient has intraparenchymal contrast and the hemoperitoneum is present and the patient is stable, we divide the patient in a minimal hemoperitoneum versus a moderate large, and we measure the size of the blush. The question is the size of the blush of 5 to 10 or greater than 10 prognostic? And should one accept a blush of 5 to 10 and not embolize the patient? My personal experience, mostly based on splenic injury, is that if you have a blush less than 10 millimeters and you do not have a large hemoperitoneum, moderate or large, we do not embolize. And over 90% of the patients are stable and they don't need anything. Should this be generalized? I cannot support this based on level 1 evidence, but this is what we do, and we have been successful 90% of the time. If conversely, the hemoperitoneum is large, with the Featherly, you have the 2 gutters, the perisplenic perihematoma, the Morrison, and the pelvis. Those patients basically undergo angiography, and we then discuss with the interventional radiologist a preemptive angioembolization based on the presence of a blush. Now, intraparenchymal contrast only, without hemoperitoneum, we do not do anything. We admit them to the unit, we do serial hematocrits, and we monitor them for 48 hours. If these patients require a blood transfusion, any blood transfusion, we repeat the CT scan, and then if there is a contrast, extravasation, this patient go to angiography. So this is our approach to hepatic trauma, and the unstable patients are divided in responder and non-responders. All non-responders go to the OR. The responders go to CT scan, and then if they have a blush and the blush is 10 millimeter, greater than 10 millimeters, and there is a large hemoperitoneum, we embolize them. If they do not have a blush, they go to the unit. If they are stable, we get a CT scan And we divide them in type 1, which is free extravasation. They get angioembolization. Type 2, as previously mentioned, they are stratified either in angioembolization monitoring. And type 3, they are observed without any other treatment. So is there a role for a non-operative management of a stable penetrating right upper quadrant gunshot wounds and stab wounds? We have evolved, and we routinely do not operate on patients who can be evaluated clinically, who are stable, who do not have abdominal tenderness and have a gunshot wound limited to the right upper quadrant and with a pathway limited to the right lobe or the left lobe, although most of the time is the right lobe. Basically, the presence of fluid, if the patient has fluid, is stable, and some of the fluid has mixed density. Okay, so you do not have pure blood, but you have a mixed density. What we do a laparoscopy to make sure that we're not missing another injury. If there is any question about an injury, we then do a laparotomy. One of the things that we believe is that if you are approaching a patient with a gunshot wound to the liver and you will treat them non-operatively, the same surgeon should evaluate the patient 3-4 times a day, not different evaluators, because there is a difference in the ability of people to evaluate the injury. What are the contraindications to non-operative management of gunshot wound to the liver? Obviously, you're unable to perform a reliable clinical examination. You have free air or retroperitoneal air, suggestive of duodenal injury, presence of free intraperitoneal fluid with a mixed density. You got to assess that.
Dr. Marini, we are not listening to you. We are not hearing you.
Check your microphone, Dr. Marini.
Can you hear me?
Yes.
Yes, perfect.
Okay. Sorry about that. So I was reviewing the contraindication to the non-operative management of gunshot wound, which means if the patient cannot be evaluated clinically, that's the contraindication. If you have free of intraperitoneal air, the presence of fluid of mixed density, and localized bowel wall thickening, the bullet track goes close to the colon, and it looks like there is an hematoma and high energy penetrating trauma that here we believe is a 38 Magnum. So what are the preoperative considerations before you go to the OR and open up the patient? You should be aware that non-operative management is successful in the majority of patients with blunt liver trauma. And don't proceed to open surgery unless you've exhausted all non-surgical options. One should remember that even for great surgeons, emergency surgery is associated with a minimal mortality of 30-35%, unless you proceed with a damage control resuscitation and damage control surgical approach. And you must decide about this approach early on. If you decide about damage control surgery after an hour, the chances are that you are too late. It's possible the patient by that time is cold and will be coagulopathic. If you're going to take the patient to DOR, make sure you have the vascular clamps as part of your trauma set, and importantly, have available the tools that will help you control the bleeding: Arco-Beam coagulator, LigaSure, the endovascular GIA, the Aquamantis. Most liver centers have the Aquamantis, which is a useful tool to use. Consider preliminary control with Riboa in patient with a base deficit greater than 10. Get a baseline thermograph. We use rotational elastometry, and we routinely get a baseline thermogram. If available, it's okay to ask for a nephral pancreatic surgeon if you are dealing with just hepatic vein injuries or retropatic caval injury. Keep the surgery to less than 60 minutes. This is the Aquamantis. This is the one that we use. It's a useful tool that the hepatobiliary-pancreatic surgeons use, and they should be part of the armamentarium of general surgery and trauma surgeons. So what should you do before you open the patient? You should insert a cordis above it, below the diaphragm, if it's possible. And if check the base deficit. And if it's greater than 10, already think about it. You're going to do damage control resuscitation, a damage control surgery. Set up the Thermacore. The Thermacore is this device. It doesn't cost a lot of money. It has a cartridge and is the best device available for rapid transfusion of blood products. Activate the MTP. Send the first specimen for TEG or ROTEM. Do not aggressively start the MTP as long as you can maintain the blood pressure 60 to 80. Cannulate the femoral artery for reboil deployment. Prep chin to below the knee. If the blood pressure is 6 to 80 with a tense abdomen, don't open until you have a reboa in place for its zone 1 deployment. Before you open, inflate the balloon, let the pressure go up, and then you open, because if you open without controlling the aorta, the patient probably would end up with a cardiac arrest. Don't start aggressive volume resuscitation until the bleeding is controlled. It's okay to have the patient with blood pressure 60, 70. If the blood pressure is 90 to 100 and the base deficit is greater than 10, insert the reboa, but do not inflate the balloon yet. Remember your standard steps for the lab: control the bleeding, control the spillage, assess all injuries, prioritize repair. Don't forget to check the diaphragm. This is the new reboa. I train with the old reboa. You have to deflate the arm flats and all of that. This is a very thing easy. As long as you have the arterial cannula in place, this is very easily deployed. It's a self-guiding, and its zone 1 deployment is a life-saving measure. In fact, we are opting to give up resuscitative thoracotomy for zone 1 reboa deployment, because there is no evidence that a resuscitative thoracotomy with open cardiac massage is better than a zone 1 deployment with external CPR. So what are the choice of incision and what do I prefer? Basically, I prefer the midline laparotomy with a median sternotomy. And if I have a major right lobe, I would extend that to a right subcostal incision. Some other surgeons prepare the Mercedes-Benz incision, which is the subcostal with the sternotomy. And other people believe a right-sided thoracoabdominal approach, which I disagree with. So now you open the belly. What do you need to do? Well, first thing, get your assistant yourself, compress the lever, stop the bleeding, and let the anesthesiologist catch up. And pack. And if the packing is not working, do a Pringle. And this is the approach popularized by Pachter. It's a step where after the Pringle maneuver, he suggests the finger fracture the lever to achieve exposure to the bleeding vessel within the depth, ligate directly the vessels and the bile ducts, debride the non-viable hepatic parenchyma, filling the defect that you have created with the pedicle of momentum, and put a lot of drains. Is this approach still valid? I believe that this cannot be generalized. It should be used for individual patients. And the question is it okay to put a pack in the liver crack? The answer is no. If you pack a liver crack, you make things much worse. So do not pack the liver crack. Just bring the liver in its anatomic position to try to minimize the bleeding. So Pringle described the maneuver in 1908, and he wrote, "Rupture of the liver is fortunately an accident not often met, but one which, when it is seen, may be associated with a condition as serious as anyone can meet with within surgical practice." This is a key maneuver. It's diagnostic and therapeutic. So what are the results of the Pringle? Basically, the slows that control the bleeding, you have an arterial or portal vein bleeding. So you keep it there for 15 minutes, you reassess, and you can decide what to do. The Pringle doesn't slow the bleeding. You have a lot of dark blood coming from the underliver. On the right, you have probably a retrohepatic venous injury. You got to confirm it. So first thing, ask the anesthesiologist to disconnect the patient from the ventilator. If you do that, the peak airway pressure goes down to 0, and most of the time, the bleeding should slow down. If that has happened, basically you have a confirmed hepatic vein injury. Now you got to make a plan and proceed. One way to buy time is transect the falciform, put a Kelly on the falciform, push the liver back and to the left. And that will slow down the bleeding, and sometimes basically it slows down or controls it completely. What this does allow you now the time to think what to do. So the Pringle doesn't slow the bleeding. The blood looks arterial. Basically, what you're dealing with is an hepatic artery that is originating from an anomalous origin. You have the reboiling place inflated balloon. Basically, the bleeding is controlled. You know that you have an abnormal hepatic. And then if you are in any bleed room, shoot an angiogram and control that vessel. What are the three most commonly used ovary approach to hepatic vein injury? One is the direct suture repair of the bleeding vessel with or without vascular exclusion, using a finger fracture technique or using a Kelly or a blunt instrument or the back of a knife. One is the lobar resection. The third, intraparenchymal perihepatic packing. I would say intraparenchymal packing should not be done. Things make worse. Perihepatic packing is definitely the way to go. So what to remember before I proceed with Roy? I'm a great surgeon. We all think we have a big ego as surgeons, so I'm going to operate. Remember that the hepatic veins, including the retrohepatic cava, is a low pressure system. The pressure in the system is between 5 and 10 millimeters of mercury. If you put enough pressure on this and you establish the containment, you can tamponade it. Don't think that you must go for the injury. Try to contain the injury. Don't fix it. A retrohepatic venous injury bleeds freely only if you break the containment. So if you have a type A injury, try not to break the containment. Don't take down, don't mobilize the liver. Mobilizing the liver is asking for trouble. Leave alone the contained retrohepatic hematoma. So you have a gunshot wound, a stab wound, you have blood coming, but now the blood is not there. There is a middle oozing. You have a contained retrohepatic hematoma. Leave it alone. Unfortunately, during my early career, we explored all these, and we end up losing the patients. And it's okay to leave a retrohepatic cava injury with a contained hematoma and a hepatic vein injury without exploring it. In fact, most of these patients will survive without a problem. But now you have decided to fix it because you are a big shot surgeon. How should you approach it? Well, if you have a type A injury, you should proceed with an anterior approach without mobilizing the liver. Don't cut the falciform, the coronary, the triangular, because these are the structures they are containing and making easy for you to control by tamponade the bleeding. If you take down the ligaments, you are making the injury uncontained. Your packs are less likely to work. This injury typically does not require a total vascular exclusion. The posterior approach to type B, this means the injury to the extraparenchymal hepatic vein injury, whether it's the right or the left. It requires complete mobilization of the liver, but it's a recipe for disaster if you lose the containment. So do not start mobilization unless you have a plan what to do to avoid that the patient is exsanguinated in the operating room. Typically, they require total vascular exclusion, and the hepatic vein is controlled outside the liver, hopefully before the patient is exsanguinated. This is the anterior approach, and we routinely use the omentum to plug in the anterior approach. When you have clipped or suture ligated vessels, use the omentum and use at 0 chromic on a large needle and with a blunt tip to take bites And the best way is to use figure mattress sutures. Just don't kill the omentum, just squeeze down. Because if you kill the omentum, and basically you're going to necrose the edge of the liver and you're having worse problem. Why is the omentum a great idea? Some people believe you shouldn't use it. I believe you should use it. It exerts a hemostatic tamponade effect. It fills the dead space with vascularized tissue. It introduces the macrophages that are present in peritoneum, enhancing the healing, and it provides stromal cells, derived factor 1 alpha, that recruits chemokines that enhance the healing. This looks easy, the posterior approach, put a clamp and everything. This is very difficult to do. Most people in elective surgeries is to do. In emergency situation with hepatic vein injury, whether it's the right or the left, it's very difficult. I think before you try to do this, you should have a plan to do a total vascular exclusion. Now, the beauty of some of these cases is that they've destroyed themselves, their liver parenchyma. So if you have available in the vascular GIA, that's the easiest way to control really the hepatic vein injuries. So what about the atriocaval shunt? I've used it, and I will share with you my experience. There are two ways to approach this. One is to do the atriocaval shunt with an endotracheal tube. The advantages are basically you don't need the intrahepatic IVC control with a Rummel. The disadvantage, it's more difficult to cut the whole 17 centimeters from the trip with a rongeur. It's more difficult to insert. And you must keep the curve of the endotracheal tube anteriorly when you put it in, otherwise it ends up in the hepatic vein and make things worse. The chest tube, which I have used also, has the advantages because you can cut the holes more easily. You can use the Christmas tree to provide additional fluid infusion to the ET tube, to the chest tube, and it's easier to insert. The disadvantage, obviously, of this, you must encircle the cava below. This is the picture. I always prefer the chest tube, although I did 2 cases with the tracheal tube. I'll share with you what happened to my patients. So what are the steps required for an AV shunt, atriocaval shunt? You must encircle the IVC above the renal veins. Make sure you do knock out one of the large lumbar veins that is right there. If you knock that vein out, you're in big trouble. Mobilize the liver by transecting fast from coronary triangular. Have an assistant. You need 2 people to do this operation. Cut 2 holes proximal to distal hole, and put 2 3/0 purse string on the right auricle. After you put a Satinsky, encircle the IVC within the pericardium. Insert the shunt, making sure that the 2 holes are distal to the renal veins. Inflate the riboi in zone 1, and then snare the infracardiac and proceed with the repair. The total vascular exclusion, I have done it, and if you do this without clamping the aorta, the patient is going to die. He will have a cardiac arrest. So if you're going to plan a total vascular exclusion, either you must cross-clamp the aorta, or because this patient, we routinely would deploy the RIBOA, we would have the RIBOA available for its zone 1. And before excluding the liver, we would deploy the RIBOA in zone 1. So these are the most common indication of total vascular exclusion: a gunshot wound with blast injury to the parenchyma requiring hepatotomy, penetrating retropathetic caval injury, and the Pringle maneuver doesn't control the bleeding in a stable patient. And please remember not to proceed with the exclusion without clamping the aorta. I have done this with a Blackmore tube, and the patient with the gunshot wound that involved 2 lobes. Basically, you must inflate the gastric balloon because it creates an anchoring point, and then you inflate the esophageal balloon. The esophageal balloon, you can inflate with a manometer attached to it and decide whether or not you need to go over 40 millimeters of mercury. It's a good methodology. Don't remove it before 48 hours. Before you remove it, deflate it for 6 to 8 hours. If there is bleeding, re-inflate it. If there is no bleeding, you can remove it. The packing, okay. Packing should be done in an anteroposterior way, and you should reconstitute as much as possible the containment structures of the liver. So do not mobilize the liver, keep the phosphor intact, use 4/6 above and 4/6 below. Make sure you do not compress the IVC. If you see blood through the packs, don't say the patient is coagulopathic. Bleeding is not controlled. He's bleeding from an artery. You must make sure that you're not bleeding. Send a tag or a ROTEM and remove the packs and repringle for 15 minutes every check. The bleeding is controlled. The ROTEM shows that you're okay from the standpoint of coagulopathy. You have the same problem. You're bleeding. Probably you have an anomalous origin in the hepatic artery. If you are in an hybrid room, shoot an angio and control it. If you are not there, try to identify the anomalous branch and, if feasible, ligate it. So now you have completely damage control surgery. How do you close? What type of temporary closure? Am I going to worry I am closing too tight? I'm going to have abdominal compartment syndrome. What is the balance between closing a little tight to enhance the control of the bleeding from the liver versus the risk of abdominal compartment syndrome? Is there an objective way to decide whether or not you're closing too tight? And does monitor the peak airway pressure delta help? So I'll tell you what I do. If my peak airway pressure increases more than 10 centimeters of water while I'm closing the belly, I'm closing too tight. And therefore, I release the closure. If the peak inspiratory pressure is between 5 to 10, I accept it. Now, what is that based on? It's based on my experience with having experienced the development of ARDS and pulmonary compromise in patients that had an increase in peak airway pressure while I was closing. What closure did I use? I'm cheap, and although I'm in the US, I don't believe that you spend $300-400 to close a belly. So I use the modified bag. I take a radiology sheet cover that is sterile, and I put it in the belly. I make some holes in it. On top of that, I put a blue or a green towel. And then on top of that, I take 3 to 4 Curlicks. And on top of the Curlicks, I put either 2 nasogastric tubes or 2 JPs. Then on top of that, I put an IOBand and I put it to suction. This, you should not do this. This is the result of delayed decision to perform damage control surgery. These days, we shouldn't see it any longer. So why do I use a temporary closure the way I use it? Basically is for money. I don't want to spend more than $50, and there is no reason for a temporary closure that I'm going to keep in place for 48 to 72 hours to use the Aptera or the vacuum. I don't know what you guys do in Argentina. We may discuss it, but money is an issue for me. Although in the US, we misuse $800 billion a year in healthcare expenditure. These are some tips and tricks. Wrap the lever, keep operating room below 60, use fixed retractors, don't let the patient become cold, use a temporary bone closure to not remove the packs. So is there a role for liver transplantation? If you are in a liver transplantation center, the way we were, there is a potential role to transplant the patients. There are a couple of reviews, one of 73 patients that were reviewed by the European Liver Transplant Registry in 2016, and they had actually good survival, greater than 50% survival. And there is another review from Brazil of 46 patients that also reported a survival greater than 40%. I think that a patient that is a dramatic injury, like the one you see described by Tucker in London here, is a candidate for liver transplant. So what do? Basically, you remove the liver, do your portocaval shunt, put the patient on an immediate list, and get a liver within 72 hours. And the chances are the patient is going to survive. The question is, are you misusing organs. This is an ethical question. And is a mortality of 50% acceptable by a liver that you can save someone's life? We cannot get into that discussion, but maybe you guys can discuss that later. So what have we learned? Well, we have learned a few things. That the best way for the patient to survive hepatic injury, grade 4 and grade 5, is to do the packing. Hepatotomy, resection, a shunt. Shunt is almost 100% mortality. If you don't do anything, the patient dies, obviously. And look at the death by exsanguination. All of these patients, the packing is the only one that has a death rate of 14.3%. Although if you leave the operating room and you have blood coming through the packs, the patient will die. So don't leave the operating room and say the patient is coagulopathic. If the tag is normal and the blood is seeping through the pack, don't leave the operating room. Richardson also confirmed the issue of shunt. The shunt at the mortality 91%. Packing was the best way. This is in 2000. This was before damage control resuscitation. That means this is when we were still giving 10, 15 liters of crystalloids, when we were giving blood products without a ratio 1:1. So this is the evolution of survivorship over time by the Richardson paper. And you can see there was improved mortality. This work done by Asensio with Dr. Petrone. And look at what happened when they tried to repair the cava by a direct approach. And the mortality was 50 to 87%. Interestingly, when I reviewed the paper that they wrote, 69% of their patients died because they were packing the patients. And I wondered, they didn't give the timeline of the packing. If you're going to pack a patient 2-3 hours into a laparotomy, packing is not going to work. The patient is going to be coagulopathic. He's getting 10 units of blood. The temperature is 32 degrees, not clots. So when I saw this data, which does not correspond, this paper is from 2003, does not correspond to what we learned today. So this is an improved outcome, and this is the impact of damage control resuscitation. What is damage control resuscitation? It's limiting the amount of volume with crystalloids and giving blood products in a 1:1 ratio in a manner to optimize perfusion. The data here shows 180 patients who underwent the resuscitation with damage control, no damage control resuscitation for grade 4 and 5 injuries. 80 were alive, basically out of 108, and 28 died. The mortality was 74%. Damage control resuscitation came into place. 6 died. The survival improves from 74 to 94%. What was the difference? Well, here is the difference. What you can see here is the survival directly correlates with the decrease in blood products, crystalloids. The median amount of fluid that improved the mortality from 74% to 94% was giving the patient 4.1 liters of crystalloids and reduced the amount of blood products to 6 to 10 units the most. One thing that was fascinating here, that look at the shape or the slope of the curve of the patch cells decrease versus the fresh frozen plasma. We did not continue to go to the 1:1 ratio until 2009. So here they decrease the red patch cell transfusion, but they continue to give a fresh frozen plasma to the patient. So this is the approach that is used in Europe. Is a very good approach, and basically it corresponds to what we've discussed so far. So what is the most recent data from the US? 11 centers in New England, the level 1 and level 2, randomized patient basically to a non-operative and operative management between January 1st, 2000 and January 31st, 2010. 131 patients were operated on immediately for hemodynamic instability, and the mortality in this patient was 52.7%. 262 patients underwent non-operative management, and 23 failed, out of which liver-related were 17, 7 had recurrent bleeding,
10 biliary peritonitis. However, the liver-specific failure rate was 6.5%. The non-operative success rate was 91% with a mortality of 5.7%. So this confirmed the work by the building of the 11 trauma centers in New England confirmed that non-operative management is the way to go for grade 4 and grade 5. What about the possible deployment of a aortic RIBOA and a caval RIBOA with eventually a dual balloon deployment? This has been done in an animal model. My partner, Dr. Ravi Kumar, who is an oncologic surgeon, and we did some work on hyperthermic liver perfusion, and we developed in an animal model one catheter with 2 balloons to isolate the liver. So I see the feasibility in the future. They could have a caval RIBOA that has 2 balloons, and with the deployment, the suprahepatic and infrahepatic, and this probably could be done easily through a venous approach. What is my personal experience? So I did 8 cases, 5 with atriocaval shunt, 2 direct repairs, and 1 total exclusion. 4 blunt grade 5 with right hepatic vein IVC injury. I used the atriocaval shunt. 3 with a 36 French ST with 1 with it. They all died. Why did they die? I did not use the atriocaval shunt before close to 1.5 hours after I messed around trying to control the bleeding. I was called in to take care of 2 patients that had injury during hepatectomies. One had a right hepatic vein injury at the confluence with the IVC during right lobectomy. This patient, I did a total artery exclusion. I was able to repair it. The right hepatic vein at the junction with the cava, it was alive. One patient who had basically a stab wound to the liver, and they injured the middle hepatic vein and left hepatic vein. This is through their approach. Basically died from coagulopathy. One got shunt wound to the right retrohepatic vena cava, grade 5. I did an atriocaval shunt with a 7.5 endotracheal tube, he died. One step wound, left flow, left hepatic injury, direct repair alive. Starting in 92, these are all of the operative cases. We had over 300 liver injuries over 10 years with grade 4 and 5. Only 21 were operated. 3 grade 5, 2 were packed and angioembolized, 1 direct repair, 2 survived. This was before damage control resuscitation. 18 grade 4, damage control plus throttle plus packing, 16 survived, survival almost 89%. 2 died, 11.9%. No one died from liver-related death. So what are the conclusions? Well, grade 5 hepatic vein injuries are rare, occur in 3 to 5% of the cases. They can definitely be treated non-operatively. With the adjunct of angioembolization, the success rate in a center that uses appropriate ICU and thromboelastography or rotational elastometry can be 88 to 93%. Non-operative management can be used for non-penetrating injury, whether they are stab wound or gunshot wound limited to the liver. When operation is required, damage control resuscitation with damage control surgery, including the use of MTP guided by rote MOTEG, is the way to go, and with packing being the first option and without mobilizing the liver most of the time. Repair of the vessel is not necessary upon removal of the packs. If you have a hole in the hepatic veins and it's controlled by the packs, don't try to fix it when you go back. Doing less is superior to doing more with this type of injury. The overall mortality for complex liver trauma is decreased from over 50% in the 90s to 5 to 10%, although some centers have mortality of 20 to 35%. So as the result of what we learned over the past 30 years. And I'd like to thank your academy for the opportunity to share my view with you guys.
Thank you, Dr. Marini, for your wonderful presentation and your vast experience in the field. Really, we are all very highly impressed about that. And all our participants, we have 80 people participating in the YouTube channel. they are sending a lot of very positive comment, but not yet any questions. So I will ask Dr. Patricio Petrone to make a comment on your presentation. Como ustedes saben, el doctor Patricio Petrone es director del Departamento de Investigación Quirúrgica en la New York University, en Langone Hospital, en Long Island, y es una persona altamente reconocida en el ambiente de la cirugía del trauma. Es colega también del doctor Marini, de forma tal que le hemos pedido a él, que ha tenido la amabilidad de conectarse también, de hacer un comentario para la audiencia quirúrgica argentina. Patricio.
Muchas gracias, doctor Figari, por esta oportunidad de hacer comentarios. And thank you very much, Dr. Marini, for your wonderful presentation. As I always said, we continue learning a lot from you, so I appreciate very much that you took the time and to expose your great experience. If you don't mind, I will continue a little bit in Spanish. I will speak slowly.
Go ahead.
No tengo mucho más para agregar. El doctor Marini creo que cubrió absolutamente todo lo que uno puede llegar a decir sobre esto. Es importante que las lesiones de las venas hepáticas junto con las venas mesentérica superior y la porta, si bien son de rara presentación, son devastadoras, ¿no? Las tasas de mortalidad son muy altas, pueden variar del 50 al 100% para las venas hepáticas, para la vena porta, y entre un 30 y un 80% para las lesiones de la vena mesentérica superior. La mayoría de las muertes suelen ser por resultado de la exsanguinación, y que esto conlleva un shock hemorrágico en muchos pacientes que mueren la gran mayoría antes de llegar al hospital. Muchos de estos pacientes también son sometidos a exploración quirúrgica, pero la supervivencia es difícil de lograr en muchos casos debido a la gran complejidad de las lesiones asociadas que también llevan. Y el control de estas lesiones muchas veces se hace muy difícil debido a la ubicación también anatómica. También hay que tener en cuenta que muchos reportes que se han hecho hablan de diversos factores que pueden ya hablarnos con anticipación acerca de el riesgo de mortalidad que tienen estos pacientes, como tener en cuenta la presión arterial sistólica inicial, el Injury Severity Score, o el grado lesional, los requerimientos de transfusión y la presencia de lesiones asociadas, como había dicho. Entonces, como sabemos que el aporte de la mesentérica también tiene una localización anatómica única, y también es variada la tolerancia que tienen para la ligadura, ¿no? Para todos los tratamientos. Entonces, mientras, por ejemplo, las venas hepáticas tienen una mejor tolerancia, ya que en el caso que sea afectada una de ellas tenemos dos venas más que pueden suplir por la colateralidad que tienen. También tenemos que el tema de las venas mesentérica superior o la vena porta puede conducir a un menor grado de isquemia intestinal e hipertensión portal comparada con la ligadura de la porta, por supuesto. Y por otro lado, sabemos que las lesiones de las venas hepáticas, junto con la porta, triplican el riesgo de mortalidad cuando se la compara con las lesiones del SMB, ¿no? De las lesiones de la vena mesentérica superior. Y esto fue reportado en un artículo que hicimos también desde Los Ángeles, fue publicado en el Journal of Trauma en 2007, en la que la mortalidad de la vena mesentérica superior también aumentaba hasta casi un 100%, cuando se la asociaba con una lesión de vena cava inferior. Un comentario que me gustaría hacer acerca del comentario que hizo el doctor Marini acerca del artículo que publicamos en el 2003. Dicho sea de paso, muchas gracias, doctor Marini, por haber mencionado ese trabajo. Sí, fue en un momento en que todavía no estaba en pleno auge las cirugías de control de daño, ¿no? El Damage Control Surgery. Y eso dio lugar a que publiquemos 2 artículos más, en el cual en uno de ellos justamente creamos las guías para cuando los pacientes tenían que ser sometidos a cirugía de control de daños en lugar de continuar con la cirugía y terminar todos los recursos, o todo el resto fisiológico de estos pacientes, como dijo excelentemente el doctor Marini, ¿no? Si uno tiene que estar 60 minutos en el quirófano y sigue sangrando, ya ha perdido el tiempo más valioso que puede haber tenido este tipo de pacientes. Así que ese era solamente el comentario acerca de aquel artículo. Y tengo 3 preguntas nada más para hacerle al doctor Marini. Voy a hacer las 3 preguntas Do you prefer to ask you the question in Spanish or in English?
No, in English.
In English, okay. Okay, so the first question is, what is the most common mechanism of injury that you have seen in your career? Blunt or penetrating? The second question is, because of the examination, the death due to examination is close to 92% of the cases. So what do you think is the role in adopting the MTP, the massive transfusion protocol, in increasing the survival rate? And going to the same token, what do you think about the EMS, the emergency medical transport services, when they are taking the patient close to the hospital? Because we know that all the patients used to die before arrival to the hospital, but now we have increased the services, and now we have seen more patients arriving in the critical state. So these are the three questions. What is your experience in the mechanism of injury, blunt or penetrating? Your experience with MTP, if it's playing any role, and also the transport. And thank you again.
Thank you, Patricio, for your comments and questions. Dr. Marini?
My first, the answer to the first question, that the majority of patients that I've treated personally have suffered liver injury from blunt trauma. As I mentioned during the presentation, the majority, in the beginning of my career, the majority of these injuries that I operated on were grade 1 to 3, which today we would never operate. The percentage of penetrating injury that I recall during about 25 years of my career is fewer than 20% have been penetrating, 80% have been a blunt trauma. With respect to the role of the MTP, I think the initiation of the MTP early on in a patient with borderline stability and that through it should not be done. You should not pour in 4 to 6 units of blood before you have a full control if the patient has a blood pressure of 60 to 80. You should deploy a REBOA, and then you should activate the MTP, but wait until you go to the OR with the REBOA inflated before you start aggressive MTP. I think the MTP should be guided by either ROTEM or TEG. And because it's important to point out that the baseline TEG or ROTEM, because some of these people may be already in a fibrinolytic state. And if the TEG or the ROTEM shows more than 5% fibrinolysis, that's very important for you to know. With respect to the third question is, as you probably recall, the time from the scene to our trauma centers in Westchester was less than 44 minutes, with the majority of critical patients being able to get to our facility within 15 to 20 minutes. We were able to save some of those patients. And the question whether or not they should receive fresh frozen plasma, I believe that there is evidence that those patients should receive fresh frozen plasma. As you probably recall, the secondary transit that we got after 3 hours, even with relatively less severe injuries, they tend to have a higher mortality. So it's key that these patients should be transported to the trauma center that can be packed them. Now, depending where you are, I don't know the situation in Argentina, whether rural surgeons can be pack the patient, stabilize, and then transfer. But in our area, as you know, some of the surgeons were unwilling to come in and take care of the patient. So the patient remained unstable. And when we got them to our centers, they died. So those are my answer to your questions. I don't know if they satisfy your questions.
Thank you very much, Dr. Marini.
You're welcome.
We have some comments and questions from the participants on our channel, and Dr. Montesinos and Dr. Leme will try to transform. Dr. Eskenazi, Dr. Verde, and Dr. Barilaro send some questions. Dr. Montesinos?
Yes, Dr. Eskenazi asked if there is any place for laparoscopy in liver trauma.
Yes, there is a role only in patients that have some questionable house-filled units fluid. If you have 10 to 20, and you have a documented CT scan liver injury, we routinely do laparoscopy to rule out a bowel injury. But with respect to the treatment itself, we do not allow MIS-trained people to handle laparoscopically with grade 4 and grade 5 injuries. We do not believe that is appropriate. However, I can share with you some centers believe that MIS-trained people should be able to handle that. I disagree with it, but that depends on whether you are the chairman and you allow them to take care of complex trauma.
Thank you, Dr. Marini. Dr. Leve?
Dr. Juan Manuel Verde from Francia, from French, is asking if the high-frequency ultrasound has any role in the non-operative trauma control.
Dr.
Yes, I do believe that radiofrequency ablation, whether it's percutaneous and operatively, has been shown to be effective in low-grade liver injury. They are bleeding. I do not have direct experience with percutaneous for trauma, but I believe the same principle apply. So I think if you have that capability, there is a role. Obviously, I don't believe that they are as effective for a complex grade injury, but it would be nice to do a trial, although I don't know whether or not an IRB will approve such a trial.
Good. Thank you, Dr. Marini. Dr. Montesinos, I think it's a comment of Dr. Barilaro.
Yes, Dr. Barilaro, of course, this is an excellent presentation. He says that in Argentina, our experience is that the only survival patients were those that have been using packing with or without the plastic bag. And now, Dr. Pfaffen asked how do you deal with postoperative SIRS, particularly when you have to reoperate a patient?
Thank you,
Okay.
Dr. Montesino. Dr. Marini?
So basically, all of these patients, as you know, get resuscitated in trauma intensive care unit. The question is, do you apply to this type of trauma patient the principles that you apply to the septic patient with respect to restoration of microcirculation to avoid the development of multi-organ failure? I personally use the PCO2 delta gap to decide whether or not I'm properly resuscitating the patient. But I'm trying to keep the volume overload to less than 10%. So what we do in our unit, we measure the delta PCO2 gap, which is a reflection of the microcirculation, and without increasing the volume expansion more than 10% volume overload. It's a difficult balance, but that has been shown to avoid the progression of the inflammatory response to multi-organ failure syndrome. I cannot go in detail in the microcirculation in the trauma patient as opposed to the septic patients because the recruitment of capillary in trauma patients is much easier than the septic patient. And whether there is a role to monitor sublingual microcirculation in trauma patient has not been really addressed. But my personal experience is I monitor the delta gap PCO2, which reflects the microcirculation, and I use that to guide my resuscitation without exceeding a 10% volume overload. I don't know if that answers his question.
Thank you, Dr. Marini. Yes, I don't know if Dr. Tymiński would like to make a final comment regarding probably the management of the liver trauma in Argentina, and then we will close the session. Dr. Tymiński?
I think you guys are very good down there from what I read.
Thank you.
Gracias, señor presidente. Thank you, Dr. Marini. Wonderful, wonderful lecture and experience. In Argentina, we have some other problems. We don't have trauma centers and don't have trauma surgeon. So the liver injury receive the treatment that not the useful treatment is just the treatment each place can do, or each surgeon can do. But I agree with Dr. Marini that non-operative is a safe treatment. Sometimes we receive a question, don't you like OR? Yes, I like OR. I don't like cemetery. And I don't like to kill patients. Thank you, Dr. Marini.
Okay.
No problem. I did not know that you guys do not have a trauma system with liver center designation.
Well, as Gustavo commented, the organization of the trauma, despite the fact that there are many very experienced surgeons in the management of trauma, the organization from the government is not organized in different levels of trauma centers as it is in the United States, and also the referral of patients sometimes is not following the more logical ways. This is probably what Gustavo commented, that sometimes you have not the best surgeon receiving the more complicated cases, but anyway, we all agree that the non-operative treatment really is a fantastic possibility for this type of patients. There is another comment from Dr. Verde, who also asked from France 5 minutes ago, and the question is if you have experience using intravascular ultrasound in the diagnostic stage or the follow-up of the treated patients.
I personally do not have experience, but a colleague of mine has done IBUS, and it is a good modality. Another, the last point I want to make with respect to return to contact sports, because a lot of people ask, so you say this patient with grade 4, grade 5 liver injury, when can they go back? How long does it take to heal the patients? So I was involved in a study looking at 1,100 children and a little over 200 adults with liver injuries. And basically most children had complete healing by 6 to 8 weeks. The adults tended to have a delayed healing, but better than the spleen, about 12 weeks. So we do not allow return to contact sports, football, soccer, unless the CT scan showed complete healing, and we do a CT scan typically at 12 weeks. I don't know what you guys do down there, but that's what we do here. For medical legal reasons, we want the CT show complete healing.
Thank you, Dr. Marini. Well, we have no more questions here, so from my side, on behalf of the Academy of Surgery, I thank you very much for this possibility. The virtual world has offered us a possibility, even in COVID times, to attend fantastic lectures, but we really hope to have the possibility to have you face-to-face in Argentina in a very short time, probably next year. And thank you, Patricio, also for the possibility to make the bridge with Dr. Conrado Marini, the same to Dr. Tismineski, and also to have supported this session with your comments. No habiendo otras cuestiones que tratar, los invitamos a la próxima sesión del miércoles 29 de septiembre. Como el doctor Montesinos ha comentado, se va a discutir el impacto de la pandemia por COVID-19 en la formación de los alumnos de la carrera de posgrado de cirugía general en un hospital COVID-19, y será del grupo del doctores Cambialtes, Gabosto y colaboradores, y que será comentado por el doctor Luis Sarotto.
Doctor Figari, presidente.
Sí, perdón, Patricio.
Sí, septiembre 29 es hoy.
Perdón, 6 de mayo.
Sí, perdón, 6 de mayo. Es un, mecánicamente, pero es un error.
6 de octubre.
6 de octubre.
No vamos a continuar con otra sesión en el día de hoy. Thank you very much again. No habiendo otros temas que tratar, damos por concluida la sesión. Buenas noches y muchas gracias.
Thank you for everything and have a good night.
Thank you.
Muchas gracias.